It is my pleasure to introduce our next speaker, Dr. Oh, sorry. Yeah.
Sorry, go ahead.
So is Dr. Andrew Hendifar. He's a medical oncologist at Cedars-Sinai, and what he's going to talk to you and summarize as well, and go over the different medical therapies for neuroendocrine tumors. A fun fact from Dr. Hendifar is that his patient and a Loch Ness born mermaid, Miss Mary Dunleavy, forced him to start swimming, and since then he have done several triathlons, and most recently the peer-to-peer swim, which is the swim Mary competes in every year. So welcome, Dr. Hendifar.
And she did, in fact, force me. That is 100% true. It is. If you want to hear the story of how Mary made me swim, come see me after this. Persuasive. What's that? You do not want to see my slides of me swimming. Okay, so I'm going to speak a few minutes about medical treatments for neuroendocrine neoplasms, which are tumors, just different types of wording and language that we use that's sometimes confusing. Okay. Now, I know this is a little bit complicated. Lisa was upset with me. She said, this is but I frequently have to educate the fellows, which are the doctors who just graduated from the residency program in internal medicine. And I promise you, you know more about neuroendocrine tumors than they do. So I think it might be at the right level. And these are the main things that I always want them to learn, because I don't have much time sometimes. You know, I'll see someone for only a few minutes. And these are the lessons you need to really take home. So the first thing that really determines what type of treatment you receive is the way we describe the tumor. It's we either call it a tumor or we call it a carcinoma. And on the left here, you see a tumor, and on the right, you see a carcinoma, and that's a path slide. So really, this is all about the pathologist's description of what they see on the slides. And that really determines almost all of what we do. Tumors are always well differentiated, and when they're graded, they're usually grade 1 or 2. They can sometimes be functional, and we love tumors because there's a whole lot of different types of treatments we can give them. A lot of them are targeted, and they're great. Carcinomas, those tend to be poorly differentiated. They're almost always grade 3. They almost never produce a syndrome, or they're never functional. And unfortunately, the only medical therapy we have right now is chemotherapy. But immune therapy is probably number one question from my fellows and from my patients. And immune therapy can work for carcinomas. So just keep that in mind. It's not for every patient with the carcinoma, but it can work. So top 5 principles of medical care. Again, this is what I teach all my trainees. Number 1, and there's a reason why it's number 1, is that not all tumors need to be treated. And this is something that you'll hear a lot. This is something that sometimes people think I'm lazy. Like, why don't you want to do something? Aren't you supposed to do something? Well, let's talk about this. First of all, surveillance or watching can be very active. It is not an active omission. You're actually doing something. You're keeping an eye out. You're keeping an eye on the patient and the tumor, making sure everything is okay. This is a very important aspect of the care for those with non-functional tumors. Again, not everyone needs treatment. Sir William Osler, he's the doctor's doctor, they call him. I just learned today he was Canadian when I was preparing for this, which I didn't even know. But he said something very profound. He said, whenever you treat a patient medically, they have to recover from the illness, and then they have to recover from the medicine. So you have to remember that. So if you don't have to treat, it's probably better if we don't. And medications usually only help when they are indicated. Some doctors will sometimes treat you outside of an indication because they kind of are treating the patient, not just the disease, and sometimes that isn't, they'll do that. But in general, we try to keep to the indications because the most important principle of what we do for our patients is we do not cause any harm. Second principle, somatostatin analogs are the first-line treatment for well-differentiated NETs. And all our bums do not feel good about that, but that's just that's the best treatment we have for the first treatment. And I made this morning. So a neuroendocrine tumor cell, we can target it. And the way we target it is we base it on the somatostatin receptor. Now, Dr. Martin will explain to you how we use imaging to figure out whether or not your tumor has these receptors. Here they look like little Ys that are on the tumor cell. So basically it's kind of a hook, and we can give a medical treatment. And the most common medical treatments are somatostatin analogs. Traditionally they've been subcutaneous or intramuscular, but if you go to the booth here, you can learn about a new oral medication that's being developed and it's in clinical trial. So this is the mainstay of treatment. This is why a lot of our patients get this very frequently. And it should usually be the first treatment you receive. Now this is based on decades and decades of work. If you go back 20, 30 years, we would give these injections to treat carcinoid syndrome. But then we'd realize that actually it can stop the tumor from growing. So now we give it for both. And several randomized trials, here you see a study from New England Journal of Medicine that have shown that these treatments can really help patients quite a bit. And we give them for almost any patient that's well differentiated, that's low grade, and that on the gallium-68 or any type of imaging scan shows that they have the somatostatin receptors. Now the third principle, there are medical treatments called capecitabine and temodar. These are technically chemos, these are chemical therapies, but we can give them as pills. And these work really well for well-differentiated pancreatic neuroendocrine tumors. For the other neuroendocrine tumors, it's not so clear. It can work for some, maybe not for others. You have to talk to your doctor about that. But as a general principle, they work really well for PNETs. Here we see that with pancreatic neuroendocrine tumors, when you use these two pills together, patients can get benefit for 2 years, which as a doctor who treats cancer patients, having a treatment that can work for 2 years is an amazing thing. And not only does it work to stop them from growing, but it actually can induce shrinkage. This is called a waterfall plot. Again, I'm sorry for being technical, but down is good. That's shrinking. Water falling. Right. All right. I think I'm ahead of schedule. Fourth principle, and I'm stealing your thunder from later, I'm sorry. And I know we take medical, we say it's medical, it's like it's not medical treatment. It's a nuclear treatment, but okay. But peptide receptor radiotherapy, because it's given through a vein, I'll talk about it for a brief minute. This is a very important treatment for patients with well-differentiated neuroendocrine tumors. It's approved for those, we call it, it's a new thing, gastroenteropancreatic. It's the made-up thing. We made it up. It's basically here to here. Here to here. I'm embarrassed in front of Dr. Gandhi. Your stomach, your intestine, your pancreas, your colon. But we believe that it can also help a lot of patients with lung neuroendocrine tumors. So for those with lung neuroendocrine tumors, there's a great study right now. It's from the Alliance Cooperative Group. It's giving patients either peptide receptor radiotherapy or everolimus, and they can cross over. Really important trial. But the approval currently are for tumors of the pancreas, intestine, colon, well-differentiated, low-grade. In the US, we can't take credit for it. It's been studied for decades in Europe. A lot of it was based on, the approval was based on the Rotterdam experience. In the clinical trials done in the US, they only included the midgut tumors. But the FDA was generous to us and approved it for all types of tumors, just not lung. So we're working on that right now. And it's amazing how quickly this medicine, the uptake around the country, you can find almost anywhere in the US you can get it, which is great. I remember when we first started, people were having to travel all over the world to get this treatment. And before I forget, in the corner, there's a new peptide receptor radiotherapy that's being developed by Raise Bio. So you should probably stop by there and talk to them today if you want to know about a new one. But Lutathera has been approved. It's, like we said, it's a medicine, but it's a radioactive medicine. So me and Martin will hold hands and say kumbaya, but it's partly medicine, partly nuclear. It's an antibody and a radioactive portion of it. It's given through the vein every couple of months for 4 treatments. It binds to the tumor based on that somatostatin receptor. It gets internalized and can kill the tumors. And here's another, sorry, I apologize again, but I had no other way of visualizing how well these treatments work. I mean, peptide receptor radiotherapy, here you see the green line on top. This is how long patients receive benefit from it. It lasts for more than 2 to 3 years, depending on the tumor type. Incredible, really incredible. Okay, so, so we have a lot of words here, but here's a nice picture. This is kind of like what we'll do in the clinic. We'll have a case. You'll see either the medical doctor or the surgeon or the nuclear medicine doctor or the endocrinologist, and they'll get some diagnostic tests, some pictures, talk to the pathologist, get all this information together, and then comes decision time. How do you deal with it? You get this, what the symptoms the patient's having. So here, for example, we have a young person who has flushing and diarrhea. They were found to have a neuroendocrine tumor, and then we get a gallium scan. The gallium scan is a nice picture, and the dark spots here are where the tumors are. And this gives us an idea of whether or not the patient is a candidate for surgery, medical therapy. And in this case, the patient was a very good candidate for peptide receptor radiotherapy. They have disease in the liver and outside the liver, so that makes it a good candidate for that type of treatment. Now finally, and I think this is very important because this carcinoid heart disease doesn't affect a lot of us, actually not that many of us, but it's really important. Dr. Heidi talked about how the heart valves can get damaged. When the heart valves get damaged and you have carcinoid syndrome, and it can only happen if you have carcinoid syndrome, it won't happen in any other situation. But if that happens, you have to catch it early and you have to fix it. You have to catch it early and you have to fix it. So how often is carcinoid syndrome? It's really tough. If you read all the scientific papers, it's hard to know what percentage of patients have it. But it doesn't really matter because it only matters if you have it. So if you have carcinoid syndrome, this is important for you. You need to get at maybe every 1 to 2 years an echocardiogram to check your heart valves. It's crucial, it's crucial, it's crucial. If you have carcinoid syndrome, your chance of getting carcinoid heart disease is not insignificant. It doesn't happen to everybody. I've had patients who flush and have diarrhea for decades, and their heart valves never get damaged. I don't know why. And other patients, the first time we'll meet them is because their heart valve is damaged from carcinoid syndrome. So they don't have flushing or diarrhea. I don't know why that happens that way, but you have to be on the lookout for it. Now, medical therapies is a broad topic. We touched on all types of things. Really, this is a family of doctors. To treat a neuroendocrine tumor properly, you need a family of doctors, you need a team. It doesn't have to be a team physically placed in one place. It can be a team of doctors that at least are communicating with each other. As Dr. Heidi previously mentioned, this is essential, and that's why the care of this disease is done by a multidisciplinary team. Now, one thing we've been trying recently is if you go in a traditional model of care, when you get diagnosed with the problem, you'll see doctors kind of piecemeal. So you'll see one doctor, you'll get diagnosed. Once you get diagnosed, you'll see another doctor, maybe a surgeon, maybe the medical oncologist, then maybe the nuclear medicine doctor, and then maybe the endocrinologist. And that takes a long time. It takes months to get an appointment right now, right? And so it's very difficult and very stressful. So one way we kind of bridge that gap is, there's 2 ways really. One way, the traditional way, is we meet once in a while, and at our hospital we meet once a week. We might not need to meet that often, but you meet together as a medical team and have a conference. and you go through all the information, everybody's there, and you can kind of like, short track the care of that particular patient. So instead of waiting months and months and months, we can talk about it real quickly, we can make a decision, and we can proceed. Another model we've been trying is to actually have all the providers meet you. So this is a care model that's done in different types of cancers, and we're hoping to introduce it for patients with neuroendocrine tumors. In other words, when you come to the clinic, all the doctors and providers are there, your case is reviewed, and then you can get kind of a multidisciplinary take on how to proceed. All right. And so I think that's the end of it. So thank you for your time. It's good to see everybody. It's good to be back in person. Thank you.